This portion of CardioSource video news coverage of AHA 2010 is brought to you by Novartis Pharmaceuticals Incorporated.
The McCormick Place Convention Center in Chicago continues to draw thousands who want to learn the latest advances in cardiovascular care. Hello and welcome back to CardioSource Video News. I'm Dr. Randy Martin. An interesting late-breaking clinical trial at the American Heart Association Scientific Sessions involved gene therapy. Patients who have critical limb ischemia and who are not candidates for revascularization often have high rates of amputation and sometimes even death. So today's late-breaking clinical trial looked at the role of locally delivered gene therapy to see if it might prevent these amputations. Our great panel today and to discuss this includes Dr. Chris Cannon. Chris is Associate Professor of Medicine at the Harvard Medical School and Brigham and Women's Hospital. And Chris is also Editor-in-Chief of CardioSource Science and Quality. Next to Chris is Dr. Deepak Bhatt. Deepak is Associate Professor of Medicine at the Harvard Medical School, and he's also Chief of Cardiology at the VA Boston Healthcare System. And Tony DeMaria, Dr. DeMaria is well known to all of you, and Tony is Professor of Medicine at the University of California in San Diego and the Editor-in-Chief of the Journal of the American College of Cardiology. So Deepak, let's begin with you on this gene therapy. What's your take on this trial?
Sure. So there's been provocative data that gene therapy might be useful for coronary artery disease or peripheral arterial disease, though no one's actually totally proved that yet. This study took about 500 patients and randomized them either to an intramuscular injection of a non-viral fibroblast growth factor, so basically gene therapy, plasmid encoded, versus a placebo. And these were patients who are at high risk of having an amputation, basically folks with foot ulcers. And over the course of 12 months, unfortunately, there was no benefit observed, none at all. And what I think is interesting is that about a quarter of those patients with foot ulcers ended up having an amputation. So even though the therapy here didn't work, I think it points to the fact that PAD is really a serious disease with a quarter of patients ending up with an amputation after a year.
Unbelievable. Chris, what's your take on this? I mean, is this surprising or?
Well, it's, a lot of the gene therapy I've kind of backed off on following because there have been promising advances and then it doesn't bear out in the next study. I think the key point of how critically ill these patients are and trying to maximize the therapies that we do know about and push a little harder on revascularization, that there more and more can be done peripherally, so that, maybe that would be the area of focus.
Tony, should we be looking, if this doesn't look as promising, should we be looking at earlier interventions in these people?
Yeah, I think we know that this works in animals. This is kind of another example of an intervention that's successful in the basic laboratory but fails when you take it to the clinical setting. And so there's the potential there to really create some good. You have to wonder the strategy of giving an intramuscular injection when you're trying to reach the vascular bed, so that I would say it's unfortunate that it was negative, but it probably doesn't be the death knell of this particular approach to revascularization.
Okay, well, there's another interesting late-breaking clinical trial called ACT, and that looked at the possible role that acetylcysteine would have in reducing contrast-induced nephropathy in patients who are undergoing angiography. Chris, what do you think about this?
Well, this is something we use 2 or 3 times a day, and we'll see if that may change, because we have so many older patients going for cath and procedures, and renal dysfunction is common. So that we give N-acetylcysteine beforehand or mucomist, and then do hydration. Right. So the Brazilian group here put together a large study of almost 3,000 patients to say, let's find out. And they found no benefit of very proper dosing, and they measured sort of a 1.5 percent or 1.5-fold increase in creatinine and then other major outcomes. So that there have been a lot of small studies that were suggestive. Now in a clear study, there wasn't any benefit. So they're now backing off of doing that as a strategy, and focus on other things. So I think a useful negative study.
And will this impact our practice, you think, Tony? Or is this just common practice that it's going to take more than this?
Well, Randy, we've had data in the past that acetylcysteine really isn't effective. And one of the neat things about this study, I thought, was that they took the individual prior studies that had been done and graded them based on their quality. And the high-quality studies all showed that acetylcysteine was ineffective. It was the lesser quality studies that suggested. So I'll be interested to see if this changes very much, because it's never really been excellent data that this was effective.
It hadn't stopped the shed. It
hasn't stopped anything.
Deepak, quickly, let me ask you, from a scientific standpoint, Chris intimated that this was a really good, a well-done study. Is that correct?
I agree, and I agree with what Tony said. The other studies were not of great quality previously. Here is a large, I think, relatively definitive study that shows the therapy doesn't work. And another classic example that small studies can be misleading.
Right, so we'll see if it changes. Dr. DeMaria is going to see if it changes our practice. So we've also got a special report on telemonitoring and whether it impacts heart failure care. We'll be back in just a moment.
Special thanks to Novartis Pharmaceuticals Incorporated for supporting continuing coverage of CardioSource Video News at AHA 2010. This is CardioSource Video News coverage of AHA 2010.
Welcome back. A special report released today looked at whether telemonitoring could reduce readmission rates for patients who have heart failure. Doctors Cannon, Bhatt, and DeMaria are here to discuss the findings. Sounds like a small medical firm or a law firm, Dr. Cannon, Bhatt. So I'll start with Dr. Chris. Chris, what do you think about this study?
Well, starting out with, this is a huge problem of heart failure is on the rise, and patients get into trouble, and readmission for heart failure is one of the biggest problems that we face. And so finding ways to keep closer track of patients and not let them eat too much salt and get out of hand is probably one of the biggest problems we face. So I've been looking forward to see whether this approach might be a way to keep closer track of patients.
Tony, big economic impacts coming with this. What's your take on this study?
So the study is negative. In fact, this type of telemonitoring was no more effective than standard care of patients with heart failure. So the questions are, why? Well, first of all, the patient was responsible for calling an automated device. There wasn't a human on the other end of it. And so, in fact, 15% of patients never called, and by the end of the study, almost 50% of patients weren't complying, and so there wasn't the kind of direct one-to-one patient interaction that has occurred in other studies that has shown that monitoring was effective. So I think all we can conclude, Randy, is that this particular approach with this device was not effective.
So Deepak, Tony's making a good argument that this might have been a methodology problem in this, not necessarily that the concept is not good. What's your take?
Yeah, I agree with what Tony said, but I think this paper does point to the fact that any new technology, even one that intuitively sounds like it should work, needs to be prospectively tested. And hospitals are under a lot of pressure to reduce heart failure readmissions, and I think this paper shows that you shouldn't just go and jump on board with the newest technology that might come out, in this case telemonitoring.
Chris?
And I suppose as a device, it receives information, and the exact protocol of how that's acted upon, just how carefully were the hospitals then, calling back the patient and adjusting diuretics. So it could be that if the devices or the approach's information were used more directly, that it might, have some benefit.
Are you sort of thinking that if you pushed it from the hospital side, in other words, if they initiated the calls and things like that, or is it really the technology?
I think if they initiated the calls, it would have been better if there was a human, but as we all know, the majority of rehospitalizations for heart failure are for comorbidities and not for decompensation of the heart failure. So in just checking weight and the simple things that this automated technique did, they'd be oblivious to the comorbidities that a human might pick up.
Deepak, take-home messages on this?
Well, I think, first of all, it shows that any new technology or intervention should be evaluated prospectively, even if it sounds intuitively logical. And second of all, I think it highlights how important readmission is. 50% of the patients here were readmitted within 6 months, and of those, half of them were readmitted more than once.
Yeah, so a big deal. Chris, last thoughts?
Well, we actually have at our hospital a program with live people on the other end, and we have to talk with the nurses and say, what are our goals? Each patient has, different issues and comorbidities. And so that may be the more personal approach is the way to try and keep on top. And I think it helps. It has been helpful for the, closer monitoring, not maybe the telemonitoring.
Right. Well, if we were doing Saturday Night Live, I'd say it's good that they're live people versus the alternative on the phone. I know, but it's very good. And thanks to all of you for joining us. Remember to check back with CardioSource Video News for updates from the AHA Scientific Sessions 2010.